Hello, hi everyone. There was a connection glitch. I'm Dr. Rashi Agarwal, MD Psychiatry from here, Meerut, UP, India. I specialize in psychiatry, but we have a very special guest today, and we are going to talk everything about perinatal psychiatry, what it is, what we can do about it. The main purpose of having these lives is that we can talk about this as much as possible, and people who are listening to them or hearing these videos, they can have an idea of what's happening. Obviously, these lives do not replace actual therapy of medications, but even one person listens to the symptoms or understands the illness better, it helps us them reach the message more and more so that they can find help if they need to. So if you have any questions here, make sure you send them below and our specialist will answer them for you. We're just waiting for more people to join in. Hi Tanya, hi Kushanti. Hello everyone who's joined, thank you so much. Any questions regarding perinatal psychiatry? Hello Juhi, welcome back. Let's have a guest, I'll introduce her. Then we can start any session for today. Hello Ravi, hi, thank you for joining. Hi, so I'll introduce a very special guest. Hi, Dr. Carolina Giacobone.
How are you?
Hi, she's an MD in General Psychiatry and also she specializes in perinatal psychiatry. She is also an integrative psychotherapist. She lives in Dublin with her family. Oh my God, how many things do you do?
I do a lot of things. My life is quite chaotic. Yeah. I do research as well. I'm pregnant at the moment. I have twin girls. I have a cat, a dog. So yeah, I'm busy. Nice.
Congratulations.
I'm sorry?
Congratulations on being pregnant. How many weeks?
I'm 15 weeks pregnant with a little boy.
All the best. Oh, that's so nice. So how are you doing at the current moment?
I'm okay. I have my ups and downs with my symptoms. The first trimester was a little hard with the sickness as it happened. But I'm okay. I'm a bit tired, but it's okay. Yeah. And with the pandemic and everything, I get to work from home, to be home, so that's good.
And how's the corona situation there? I heard the lockdown more is going to happen.
It's quite bad. We're quite, going through kind of the third wave. So we're through a lockdown. Everything's closed in Ireland. We're level 5, so we're closed. We're getting tons of cases after Christmas, and that is quite bad. So yeah, we're trying to stay calm and to manage things as we can, and hopefully for February things will pick up. Yeah, how are things in India?
Things are like it's going better. Fingers crossed. I think we are going on a better side. We are waiting the vaccine, but yes, the overall active cases have come down.
Oh, good. We do have the vaccine here now. We got the Pfizer one, and they've started vaccinating the older population and the frontline workers. So we'll see how that goes. Fingers crossed.
Yeah. See, here a lot of people are not aware about what perinatal psychiatry is. There is not enough talk about it. There is no specific specialization there. I try to reach out and tell people and educate, especially women who are in the peripartum period, because I generally deal with postpartums because they're not that much aware to come to us during the prepartum period. So can you just tell us very briefly what is the peripartum period and why it needs a special mention besides from psychiatry?
Of course. Well, you're right about what you're saying. Perinatal psychiatry only started or was recognized as a field in psychiatry maybe 4 years ago. This in Ireland, where we have more of a plan of how to develop services, and we have a system of hubs and spokes. So we have a maternity hospitals around the country, and they would cover the rest of the country as well with little kind of maybe 1 to 5 a week. It's quite new, so we are understaffed. The service is like quite small. There's a problem around the world, and it's really, really important that we recognise perinatal psychiatry as a field psychology, because we're dealing with two lives at the same time. We're dealing with the mother and we're dealing with the baby and family as well. The mom of the baby. But if you're specifically talking about psychiatric disorders, then yeah, it's the mom and the baby. It's really, really important that we focus on perinatal psychology a bit more. And so many people don't know the the services are out there. We do have them in Ireland. We have them in the UK. We have them in the US and Canada, in Argentina, a number of places. But we still need more awareness. So it's great that you're doing this. And thank you so much for shedding a light on prenatal psychology. Because we need it. We need it.
See, people like you give us the inspiration who are working in this field. We try to create more awareness and talk about it as much as possible. Because here, the first referral person is the gynec. During the peripartum, postpartum period, the female usually goes to a gynec, and then it's usually brushed off as baby blues, or it will get over soon, because a lot of cultural differences are also there, that everything is going to be all right. But that's not the case, as we know always, that it sometimes need therapy and medications both.
Yeah. I know that there are cultural differences around the world, and that is something that we respect. But at the same time, there's psychiatric disorders that happen everywhere. Doesn't matter where you are, and they do need treatment. So what we usually say is your first point of contact during pregnancy might be your family doctor, your GP, or your midwife, or your obstetrician, or whoever it might be. But if you're struggling, if you feel that anything is changing in your life, if your partner tells you that they see something different in you, then just let them know. And the good thing is that GPs, midwives, anyone, nurses, they will refer you on to us, to our services of perinatal mental health. And we have a really low threshold for accepting patients. So we see everyone. We know how delicate it is. And you might not even care for your medication. You just be a social worker, or not even that. But it's better to be safe than sorry. So we always encourage people to speak up. I know it's really, really hard. For a lot of mothers, it entails a lot of guilt, a lot of shame, because they feel that they're failing already during the pregnancy. And it's not the case. They asking for help with a sign of courage and resilience. So obviously we encourage everyone to speak up, and we're always here, happy to help everyone. And if you're doing perinatal psychiatry, I always say this, it's because we love it and because we have a passion for it, because not a lot of people do it. So come to us, and we will listen, and we will try to help you as best as we can. At least in Ireland, where services are free, so you can self-refer as well, so you can come to us and we'll see you. And yeah, it's a great opportunity to screen and to prevent and to detect early if anything is going on. And as we were saying before, it's to clarify what perinatal psychology means. Perinatal psychology means that, or perinatal mental health means that we see everyone during their pregnancy, and that's the antenatal period. And then we see everyone in their postpartum until their child is 1 year old. Sometimes services are a bit collapsed and we don't have enough staff, and if the mother is doing well, we might just start them when the baby is 6 months old. But we take care of that period. And sometimes as well, we might see them prenatally. The psychologists usually might see them prenatally in case they have any concerns with fertility or recurrent miscarriages or anything past through mental illness. So we see them prenatally, antenatally, and post.
Do you think it is underdiagnosed to a larger level? Like many cases go undiagnosed.
Yeah, well, we don't have enough research to give you numbers. Unfortunately, we're only starting the clinical part of psychiatry, of perinatal psychiatry, so we don't have a lot of research. But we do know that a lot of things go misdiagnosed or just don't don't get a diagnosis at all. What happens a lot is that the only diagnosis that we knew for a very was postpartum depression. So a lot of doctors or healthcare professionals will diagnose you with postpartum depression. And it might be something else. It might be anxiety, it might be PTSD, it might be baby blues, it might be something else. So you do need to train professionals, family doctors, GPs, midwives, nurses, obstetricians, so that they can screen at least the basic knowledge of perinatal psychiatry, so that they can tell the basic difference and then refer you on to our services, where we can obviously assess you and treat you and give you a proper diagnosis.
This is a very good point that you brought up about mom guilt. Like, yes, a lot of moms in the postpartum, they come to us and they say that I am not able to take care of my baby. I feel bad. I
Yeah.
should be able to love the baby. I am not able to love. So the mom guilt plus the society pressure around that to love the baby at that time, to take care of the baby and ourselves. So they kind of, the guilt adds upon, and I think it accelerates the problem more and more.
Duh, yeah, and you touched on the main point, which is exactly such a long time we've heard people saying, oh, you have to be a natural. Having a baby means that you have to be happy at that time of your life. And it's not true for so many women. So many women that might suffer from mood disorder, from anxiety disorder, from a traumatic birth, from OCD, from anything really. So it's not true. And we need to acknowledge that a psychiatric illness is an illness. So we need to treat it. And it doesn't mean that it defines you as a mother. It doesn't mean that it defines your capabilities as a mother. You might love your baby anyway. It might take a bit longer for you to connect with the baby. And that's valid. That's fine. And we can work on that. It doesn't mean that you're less of a mother because of that. It's really important that we make the message across.
That has been ingrained so much in the brains that it is very difficult to wash that out, that it's okay if you're not able to take care of yourself or the baby, and you necessarily don't have to be happy all the time.
Of course not. It's a roller coaster of emotions as well. We need to think that there's so many factors in place. Your identity changes, your family changes, your body changes, so many hormonal changes, genetic changes. A lot of things are going on. So you are expected to feel unwell. You are expected to be exhausted. You can't sleep for the first few months. It's a massive change, particularly with the first baby. And if you have a history of a mental illness, or someone in your family has a history of a mental illness, then you have a higher predisposition to developing a psychiatric disorder. They can happen, and that's fine, and there's no shame and no taboo and no stigma. And we're here non-judgmentally to listen to your story and to try to help you as we do with everyone.
So, what led you to choose this specific specialty? Like, what pushed you to go from general psychiatry to perinatal psychiatry?
So I was doing general psychiatry when I got pregnant with my twins, and it was more personal story, and I told the story a lot of times. But my mom got sick very soon after I found out I was pregnant. And I journeyed all of my pregnancy together with her illness. My mom was back in Argentina and I was in Ireland, so I was traveling back and forth. It was really, really traumatic. Then I got very sick. I got an autoimmune disorder in my blood. I got ITP. So I couldn't travel anymore. And then when the babies were born, one of them got sick, she was in the NICU. And soon after that, my mom passed away. It was a very dramatic story, really, really hard. And I got the help from a perinatal psychiatrist back then in 2018. And I think that without him, I wouldn't be where I am today with my grief and even motherhood. And he showed me that it's the world of just, it's beautiful, the things that you can do for family from a perinatal mental health point of view. And I thank him all the time with my inspiration. And I think he's one of the most brilliant perinatal psychiatrists out there today. So he inspired me. And I felt as well that with all my experience, then I lost a baby as well last year. With all of my experience and with motherhood, with these difficulties, and with my expertise in psychiatry, that I had to give back to those mothers. And I was in a position to understand them and to have empathy for what they're going through. So I just felt fascinated for the field. And as you were saying before, there's no specific training for perinatal psychiatry, so we have to do it on our own. We have a clinical post, do some research, and I'm doing a master's in perinatal mental health. You kind of try to get knowledge where you can for a few years, and that's how you become a perinatal psychiatrist, unfortunately, nowadays. We don't have a specific training for that.
I also do personally believe whatever you go through, that shapes the future that you want to make.
Yeah.
Because whatever you are going through, and if you overcome that, I think many a times even I get that feeling, okay, if I am blessed enough to have this experience, it's better if I can share this with somebody else, or it's like I can help somebody else so they can have a better life too.
Yeah, that's a beautiful thought, and that's exactly how I felt, that I was in a better position to help mothers and babies in conflict because they understood what they were going through. So that's why I chose it, and I love it, and I don't regret it. And we need more people in perinatal psychiatry, so I'm all behind recruiting people, encouraging them to come to listen to our talks, to try to find out what it's about, and hopefully in a few years it'll be more recognised, and we'll have more resources as well.
So what are the common complaints that you see day in and day out for which people come to you for consultation?
Yeah, so I would say 40% of complaints are what we call PMADS, so perinatal mental mood disorders and perinatal anxiety, particularly in the postpartum. What I've said before, if a woman has a history of anxiety or depression, even outside pregnancy, in their life, just normal life, or in their families, and they have a higher predisposition to developing that in pregnancy. But that would be what we see the most. And usually what we say is that in the first 3 months postpartum, 1 in 5 women might develop a mental illness, which is incredibly high. And we need to talk about that. And in the first 6 months, in 1 in 7. But then again, it's because we don't screen them as much after 3 months. So we still think that it's 1 in 5, but we don't have enough research. So it's still a lot. And suicide, which is a very hard topic to talk about, but we need to, is one of the most common in mothers after they have a baby. So we need to talk about it. Because if you ask for help in time, with that for prevention and early detection, education, family, then we can prevent this. And we do have the tools to help you. So it's really, really important. So the most common complaint that we would see, as I said, are mood disorders, particularly depressive disorders and anxiety. Yeah, generalized anxiety in the form of panic attacks. We would see a lot of OCD as well, particularly in people who have a history of OCD, a lot of traumatic birth. It might then develop into PTSD, so we try to treat that. We would see a lot of grief, which really, really important that we talk about this. Baby loss. Baby loss is not talked about enough. Early baby loss, stillbirth, neonatal death, even traumatic births, having a baby on NICU, everything can cause grief. So grief is not a medical illness. It's not a psychiatric illness, but it might need the support of a trained mental health team. So grief is something that we see a lot, and thankfully our teams do have counselors, usually a bereavement midwife, or even ourselves as therapists. We see those patients, and that is a common complaint that we see. I hope that. We're still there.
There was some technical glitch.
Yeah, internet connections.
Yeah, so see here, I think anxiety is very underplayed because anxiety is just brushed off as changed. So the society or the family usually brushes off anxiety as telling them that everything is going to be fine. You don't need to worry about that. So people that I usually see come to me either in severe cases of postpartum depression or even rather in psychosis. When they feel that the mother has become like she's a threat to the child, so they come to a psychiatrist at that point where they feel that something like evidently is very wrong. So you have to counsel them and tell them about the whole hormonal balance, like if they had a family history, if she had a history of having depression or anxiety in the past. So it's like kind of difficult for them to convince because the older generation does not agree with the fact that these kind of things happen.
To acknowledge anxiety, and that's all. I suppose it's related to education. We need to educate people in anxiety that anxiety is real. As we were saying, a lot of people think it's just being overwhelmed or tired or stressed out by the change of having a new baby, and it's not that. So anxiety disorders are a true psychiatric disorder, and they disrupt your daily life, and they can become chronic and pervasive and affect your sleep. And I think there was a question about how they can affect your weight. Yes, they can affect your weight. You can lose weight, obviously. You can gain weight as well. It depends on the type of anxiety that you have. So obviously we need to recognize them. And as a psychiatrist, sometimes it's our fault, because it might happen to you as well. They think anxiety disorders are the mild disorders in psychiatry. But in the perinatal period, they're quite important. They do have an effect on the baby when you're pregnant, and they do have an effect on the baby after the baby is born. You might not connect as well with the baby. You might be completely drained. So we can help you with that. So society needs to recognize that anxiety is real, and it's much more than just being tired.
And I think the best feeling is that when the women start getting better and they come back to you with the baby and they tell you their experience that, yes, I was not in a good place, and after this medication and this therapy, now I feel connected with my family, connected with myself, and I'm able to take care of my baby. I think that day my day is made. I'm like, I'm happy. Okay, I've affected
Of
the life
course,
of
yeah,
people.
success. Yeah, of course, of course. And it's really important to say that once we achieve that point where the mother feels that she's back to normal and that she can connect the baby, we don't just discharge them, we follow them up for a little while. So it's not that we just leave them in the system and we never see them again. And usually we discharge them back to a community and mental health therapist or back to their GP. So they're in the care of a mental health professional. It's not that they're locked in the system and that they don't have any more support. It's important for mothers.
That is the difficult time to let them agree that, okay, you don't have to stop everything right now. You are in the maintenance phase. We'll taper everything down. Have patience.
Yeah, well, it happens in all of psychiatry that people get better and they want to stop taking their medications, and you need to tell them, no, you need to take them for a certain time and you need to do your therapy for a certain time. But that's part of our job and we're used to it, and it's fine. Yeah.
Thank you, Dr. Carolina. Thank you so much for answering so many of our questions. And I hope this reaches as many women as possible, even as many people, so that they hear about it. And even if they have some symptom around it, they can go to their general practitioner and discuss about it. Even if we are able to help one person, I think it's enough of a happiness for us to go and help people around.
Yeah, absolutely. Thank you so much for having me.
Thank you for agreeing to do this with me.
Thank you so much. It was my pleasure. So whatever you need, I'm always here.
Thank you. Thank you. Bye-bye.
Until next time. Bye-bye.
Yeah, surely.